everyone. Happy evening, a very good evening. I hope and I believe all of you are doing well. Before we start with the session, which is going to be a very high yield session of rapid revision of pharmacology, as much as we can do in this approximately 1 hour of session, could you give me a quick nod whether the audio visual is all good? Okay, that's great. So this is going to be a very high yield session, so in this entire 1 year of preparation, we have had so many sessions on the plus and also on the free live classes. So we are going to try and consolidate, and maybe if we are not able to complete this in the upcoming days, we will have other sessions where we will try to cover the remaining of the portion. Okay, so Sabrine, okay, what does the P corresponds to? Yes, so the YouTube shorts that was recently uploaded for the anti-cancer drugs, paclitaxel, P for promotes polymerization. Vinca, VIN, it inhibits polymerization. So Vinca alkaloids, IN inhibits, and paclitaxel, that is basically taxanes, paclitaxel promotes the polymerization. Okay, that it was. All right. So let's start. Yes, Dr. Gaurav, you might hear Kaira's voice in the background because she's all up and awake. So yes, you might hear that. I hope all of you are making the best of the plus subscription. The good news is that now you would also get the printed notes which are coming soon for students who have 12 months and above subscription. Plus the question bank has also been updated. So make the best use of it. Iconic is with Unacademy and Prep Ladder together. So you get both live and recorded, the best of it. And the special class features. So let me tell you that what is the plan for tomorrow 5 p.m. We will have a session which was supposed to be today evening itself, but we could not have it today due to some reason. The last 10 days plan, the do's and don'ts in the last 10 days, that is what is the session that we will have. So whatever queries you have regarding your preparation, whatever anxiety you have, get it on board in tomorrow's free live class. You can use code Dr. Nikita to join the class, and you can vent it out. So the best part is now you can also raise a hand and talk to me, talk to other educators on one-on-one basis and get your queries solved. So I'll try my best to give you a very effective plan for the next 10 days, what you should be studying and how you should be planning. Okay. And question bank I've already told you, and then we have the new batches which are starting tomorrow, FMG as well. The emergency MCQ batch is also starting tomorrow, and then we have for next 2022 students as well, the NEET PG 2022 subject wise batch is starting, and the last 3 years PYQs will be covered in this 1 week of batch that you have starting tomorrow. So it's gonna be 2-hour session per subject. So students who have had the 1 month subscription, remember it's not that these only you can access the past sessions as well that we have had on the platform. All right. And a grand test, very important. This is a grand test that you cannot miss, which is going to be on 4th of September. What is the unique feature? It is curated by the educators themselves. The respective subject questions are given by the educators themselves. So maybe you will get to see the questions that are expected in the exam. So make sure it's free for everyone. So all of you should appear for this grand test, which is on 4th of September, 9 a.m. All right. So without any further delay, let's start with the today's session. A quick reminder of the code whenever you are subscribing or joining the class on the platform. The code is Dr. Nikita. All right. So I hope all of you remember that. So we have multiple things to be discussed today. There are many things to be discussed. We have general radiology में से कुछ part है. We have some parts from CNS pharmacology, anti-epileptics, antipsychotics. Then we have something from antimicrobials, okay, the mechanism of drug resistance. That is what we will be seeing. Antifungals का quick review. Many other topics coming your way. And yes, then we have a quick revision with mnemonics of the drugs in diabetes mellitus. And we have antifungals, as I said, and you have some new drugs, the monoclonal antibodies, very, very important. That is what we would be seeing. Okay. Okay, Sabrina, I'll share the link. I'll share the link on the Telegram group. Whoever feels that the screen is blurred, please try increase the resolution of the video. Okay, that will help. Okay. All right. So let's start with first part, that is general radiology. Now this is a very, very important graph both in pharmacology and biochemistry as well. So if I ask you which of these is an antagonist, yes, this session is approximately 1 hour. Okay. Now consider only the drug A and drug B. Which drug is antagonist of which drug? A is antagonist of B or B is antagonist of A? Which of the following is true? A is antagonist of B or B is antagonist of A? Which of the following is correct? So whoever has, you know, the abrupt discontinuation, some issue with the YouTube, I don't know what's the issue, please go back to the link and rejoin in case if you have, you know, abruptly ended for you. Okay, absolutely right. B is antagonist of A. The one which is to the right, you can see the dose is more for B for the same effect. For the same effect, you see that the dose is more for B. So that is B is antagonist of A. Okay. Now how do you remember which is competitive antagonist and which is non-competitive antagonist? So the mnemonic to remember this, अगर graph आया और quickly decide करना है. Remember that, look at the height, A and B, they have the same height. So even if B is antagonist, they are at the same level. So they are competing with each other. So remember that your competitive antagonist, okay, the competitive antagonist, they will have same height because they are competing. This is a quick trick to remember when you see the graph, okay. Non-competitive, now C is the non-competitive antagonist of A. ये दोनों तो competition में ही नहीं है because उनका level is itself different. You compete with someone who is at the same level. Okay, you compete with someone who is at the same level. So when you have same level का graphs, okay, the height is the same. That means it is competitive, same level. अगर different level है, graph is coming down, that means they are non-competitive. Okay, they are non-competitive. So remember this quick trick, competitive, they are at the same level. So if you see, we have discussed this in our biochemistry sessions as well, right? We have discussed this in biochemistry as well. Competitive and non-competitive, what changes and what remains constant? In competitive, what changes, and in non-competitive, what changes? If you remember, in the term of Km and Vmax. Okay. So the trick to remember is competitive Km. It is K which changes. Km increases or Km decreases? Km increases or Km decreases? Remember, Km is inversely proportional to affinity. Affinity decreases, Km increases, Vmax remains the same. While in non-competitive it is ulta, Km remains the same and Vmax decreases. Please do not get confused here. Remember, Km increases. And you can also see that in competitive, what is changing? Is it the potency of the drug or is it the efficacy of the drug? What is changing? Is it the potency or is it the efficacy? So on the x-axis we have potency and on the y-axis it is the height. Height is the efficacy. Okay, so you can see that the height is the same, that means the efficacy is the same. It is the potency which is decreasing. Okay, the potency which is changing, while here the height is changing in non-competitive, that means it is your efficacy which is changing. Okay, so remember, easy trick, the first mnemonic, competitive will be at the same level, that means the Vmax, efficacy basically is the Vmax. So the Vmax remains the same. Okay, the Vmax remains the same. It is the Km which increases. So pharmacology, biochemistry integrated here. Okay, while in non-competitive you see that they are at different levels. So the Vmax is decreasing, that means the Km remains the same. Okay, now the next one, coming to your zero order versus first order kinetics of the drugs. Constant fraction of drug is eliminated in zero order kinetics or first order kinetics. Constant fraction of drug is eliminated in zero or first order. Absolutely right. So another mnemonic to remember here is, remember constant fraction. Fraction is first. Okay, fraction is first order kinetics. That is the mnemonic to be remembered. So constant fraction is eliminated in first order kinetics. Constant amount is eliminated in zero order kinetics. Okay, constant amount is eliminated. Next one, rate of elimination is independent of drug plasma concentration. Is it zero order or is it first order? Rate of elimination is independent. That basically tells you that irrespective of the plasma concentration, it is the constant amount which is eliminated. Amount is your zero order kinetics. Okay, that's your zero order kinetics. Which one has your constant T half and clearance? Constant T half and clearance is your first order or is it your zero order? Constant T half and clearance is with first order or is it with zero order? Absolutely right. Please remember, it is the first order. Remember T half. Okay, remember T half. Half is a fraction. Okay, T half, half-life, half is a fraction. Fraction is your first order. So similarly, clearance is like a fraction. Okay, so that is fraction wala, first order mein it is constant. So let us have a quick review on the difference between the two. Zero order, constant amount. First order, constant fraction eliminated. Constant amount, that means it is independent of the plasma concentration. This is proportional to plasma concentration. That is why this is constant, clearance and half-life. Here it is different. It changes with the plasma concentration. In zero order kinetics, when is the clearance more? That means more amount of drug is getting excreted from the plasma, like more amount of plasma is getting cleared. Yes, so that is at low concentration. Remember, clearance is more at low concentration. It is, that means less at high concentration. Ulta is with half-life. It is less at low concentration and more at high concentration. Do you remember from the yesterday's KBMD, Kaun Banega MD episode? The formula for T half is 0.693 into VD upon clearance. Okay, so T half and clearance, if I ask you what is the relation between the two, are they directly proportional or are they inversely proportional, right? So they are inversely proportional. So at low concentration, if the clearance is more, that means the half-life will be less because they are inversely proportional, right? So remember this very, very important formula, and it's asked, okay, and it's asked in your exam. So majority of the drugs follow first order kinetics. Everyone wants to be first. So majority is first order kinetics. Very few drugs follow zero order kinetics. We all know the mnemonic is 0 watt power ka bulb, right? 0 watt power. So you have warfarin, alcohol, aspirin, tolbutamide, theophylline, and phenytoin. Okay, phenytoin is important. Alcohol, aspirin, and you have warfarin. These are important ones. 0 watt power, we all know, is the mnemonic for your zero order kinetics. Okay. Coming to the next one, again a frequently tested in your toxicology, medicine, pharmacology, the concept of acidic drug versus basic drug, and where will you do alkalinization of urine and where will you do acidification of urine. Okay. Now when you have weak acid, a drug which is acid, when you put it into alkaline medium, it will ionize, right? So weak acid in alkaline medium, it will ionize, है ना? Opposite में it will ionize. Acid alkali में ionize होगा. When the drug is ionized, is it absorbed? No. The drug is absorbed. It can pass the membrane in unionized form. That means it is not reabsorbed. That means it is excreted. So for acidic drugs, we will do alkalinization. For basic drugs, alkaline drugs, we will do acidification to enhance their elimination, right? Now the problem here is how to remember which is acidic drug and which is basic drug. Now acid matlab, if you remember from our radiology class as well, the contrast media, which are the iodinated contrast media which are ionic. Which iodinated contrast media are ionic? So the plus subscribers, I have discussed in the plus class the trick to remember. The drugs ending in ATE, right? The contrast media, iothalamate, right? Ioxaglate, ditrizoate, all of them are ionic. Similarly here, acid matlab carboxylate. Okay, acid matlab carboxylic acid, that is carboxylate. So you have barbiturate, you have salicylate, you have valproate. All of this tell you that these are acidic drugs. Okay, these are acidic drugs. For the basic drugs, I'll come to phenytoin and warfarin later on. For the basic drugs, base matlab क्या होता है? Base matlab होता है amine. Okay, base is either amine or you can remember for your mnemonic, that is alcohol. So alcohol like your propranolol, amine का chlorpromazine, quinidine, INE, amine का INE, and diazepam is nothing but benzodiazepine, right? It is benzodiazepine, again INE. So the drugs ending in INE, okay, it should be INE, not only IN, like you have phenytoin and warfarin. They have IN but they do not have INE. So these are acidic drugs. We also know that these are the drugs which have zero order kinetics. So remember, they are exception. Zero order and acidic drugs, warfarin and phenytoin. Is this clear with everyone? Okay. Yes. So remember that yes, Neeraj, I am seeing the chat box in between whenever possible. So I am on a rapid fire revision today. So my whole concentration is major on revising too many things quickly. Yes. So is this clear with everyone? How to remember? ATE. So basically the trick to remember is ATE is acidic drug. Okay, let us revise here. Okay. So which are the acidic drugs, right? Which are the acidic drugs? Alright. So the acidic drugs are ATE wale. So you have barbiturate, valproate, salicylate, and you have IN wale drugs, warfarin and phenytoin. Which are the base wale drugs? INE wale, benzodiazepine, right? You have benzodiazepine, quinidine, chlorpromazine, and which is other one? Alcohol wala, propranolol. Okay, these are the basic drugs. So for acidic drugs, you will do alkalinization. For basic drugs, you will do acidification, right? We will do acidification of urine. Okay. Chalo. Let's go to the next point. Okay, let's go to the next point now. Ye ho gaya hamara very important point. So I think I should stick to it so that I can see the pages well. Just a second. सो ये देखा, जीरो ऑर्डर काइनेटिक्स देखा, एसिड और बेस देखा. ओके, एसिड और बेस देखा. Now coming to the next topic. Okay, the next quick topic that we are going to discuss, very important, we have discussed in one of the recent special classes, that is your anti-platelet anticoagulant drugs. Now I am assuming that you have attended the class with me, so I might go a bit fast, but anywhere if you have any query, do let me know. I will come back to that point. Okay, because this is all focused on rapid revision, so this is going to be very rapid. Okay, all right. Now so antiplatelets से start करते हैं. Which are the anti-platelet drugs? You might be given image like this, and this will be hidden or this will be hidden, and they will ask you which drug acts as this site. So you should know many images in pharmacology based on mechanism of action. Okay, it's very important. So antiplatelet drugs, we all know which is your cyclooxygenase inhibitor. It is aspirin, right? It's your aspirin which is cyclooxygenase inhibitor. Which is the drug which is phosphodiesterase inhibitor? एक डाइपैरिडेमोल है और दूसरा कौन सा ड्रग है? Which is the other drug? One is डाइपैरिडेमोल and the other one is silastazole, right? The other drug is silastazole. So you can remember this as, okay, you can remember this as, I hope you can see this. Okay, so Ajit, the topics that we are going to cover are many. We are targeting today. Antiplatelets है, diabetes के drugs है, antifungals है. There are new drugs, anti-epileptics. So there are quite a few topics that we want to cover. Yes, so remember that phosphodiesterase inhibitor, PDE. You have PDE, DP is your dipyridamole, E is like C, that is your silastazole. Okay, these are your phosphodiesterase inhibitors. Silastazole, we have read that it is phosphodiesterase 3 inhibitor. Remember, C is the third alphabet. Phosphodiesterase 3 inhibitor, what is the other action of silastazole? It has vasodilator property as well, and therefore it is used in intermittent claudication, that is peripheral vascular disease. Okay, it is used in intermittent claudication, that is peripheral vascular disease. Then you have ADP wale drugs. Okay, ADP wale drugs, which is your P2Y12 receptor, ADP antagonist. You have reversible and you have irreversible. How do we remember which is reversible? Your OR में end करने वाले drugs, cangrelor, okay, ticagrelor. So these are reversible, that means these are temporary. Okay, temporary is OR. Okay, temporary is OR. And your GRI is your basically, remember, like your platelet aggregation. So ADP inhibiting your aggregation, ADP antagonist. So automatically the rest become your irreversible. Again, prasugrel, it is GRE, like your cangrelor, ticagrelor. You have ticlopidin, clopidogrel, again GRE. So basically these are your GRE wale drugs. Clopidogrel, prasugrel, clopi wala आने वाला दूसरा drug ticlopidin, clop, right? These are irreversible. OR wale are temporary, that means they are reversible. Okay, remember they are reversible. The next you have GP 2B3A, 2B3A. So BA, AB wale drugs, okay, AB wale drugs, apcizimab. CI tells you that it's a circulatory drug. AB is 2B3A. Tirofiban, इसमें भी वापस BA आता है, fibrinogen वाला, fibrinogen. Aptifebatide, again fibrinogen वाला, BA, AB ये आता है. So basically 2B3A drugs में either BA आता है या आपका FIB आता है, fibrinogen inhibitor. Okay, remember these are GP2B3A inhibitors. Then you have PAR receptor antagonist. Okay, so PAR, Vorapaxar, Atopaxar, PAXAR wale drugs, PAR का X antagonist. So these are the Paxar wale drugs, PAR antagonist Paxar. Okay, clear with everyone? Easy to remember, right? anti-platelet drugs. Now let us go to the image now. Now let us go to the image. So first one, aspirin. Okay, this is where you see aspirin cyclooxygenase inhibitor. So how is it helping? By inhibiting conversion of arachidonic acid to thromboxane A2. So basically it is inhibiting thromboxane synthesis. Then you have your ADP which is released, thromboxane which is released, ADP antagonist. Which are the ADP antagonists? You have clopidogrel, ticlopidin, prasugrel or GRE wale drugs, right? All GRE drugs. Then you have your GP2B3A which is basically fibrinogen ko bind karne wala. So Fib wale drugs, AB wale drugs, apsizumab, eptifebatide and tirofiban. Then you have dipyridamole and silastazole which is phosphodiesterase inhibitor. They inhibit your adenosine uptake as well. Okay, they inhibit your adenosine uptake. So they increase basically your cyclic AMP levels. They increase your cyclic AMP levels. Alright. This is anti-platelet drugs. Let us go to the next one. Again, before that, a quick review. Cyclooxygenase inhibitor, aspirin. Irreversible P2Y12, that means your ADP wale drugs. You have clopidogrel, prasugrel, ticlopidin. Reversible is OR, that is ticagrelor and cangrelor. They are reversible. 2B3A is BA or AB, apsizumab, eptifebatide, tirofiban. Thrombin, that is your PAR1 receptor antagonist. Thrombin antagonist. Vorapaxar, atopaxar. Phosphodiesterase inhibitor, dipyridamole, and you have silastazole. Please remember, silastazole is used in intermittent claudication because it has direct vasodilator action as well. Okay, it has direct vasodilator action. Okay. Going to the next one. Okay, going to the next one. Now coming to anticoagulants. Okay, your XA, the factor 10A wale drugs anticoagulant में आएंगे. ये हो गया हमारे anti-platelet. Okay, that was anti-platelet. Thromboxane inhibitor, that is aspirin. ADP wale inhibitor, GP2B3A inhibitors, and your phosphodiesterase inhibitors. Now coming to anticoagulants का table. In anticoagulants, you have oral anticoagulants and you have parenteral anticoagulants. Now again, this is very, very important. Okay, again, this is very, very important. Alright. Parenteral is easy to remember, that all your parent wale drugs. Okay, the trick to remember is, the mnemonic is, all parent drugs are parenteral. Okay, so if you see heparin, unfractionated or low molecular weight heparin, be it enoxaparin, dalteparin, tinzaparin, or be it your fondaparinux, idraparinux, all parent drugs are given parenteral. None of them is given oral. In parenteral, then you have direct thrombin inhibitors as well. Okay, your direct thrombin inhibitors. How do you remember the drugs which are direct thrombin inhibitors? So remember, these are direct inhibitors, DIN wale drugs. Okay, all your DIN drugs are direct inhibitors. So hirudin, lepirudin, bivalirudin, these are direct inhibitors. Then you have troban wale drugs. Okay, troban ya tran. Troban tells you that this is thrombin ko ban karne wala, thrombin antagonist. So these are direct inhibitors. Argatroban, dabigatran. हम आएंगे उस पे. Dabigatran is given orally. Milagatran, again TRAN, thrombin antagonist. This is very, very important to know, and you have these easy tricks to remember these drugs. Okay, you have very, very easy tricks. So remember, the direct thrombin inhibitors are either DIN, direct inhibitors, or they are troban, or they are tran. Thrombin को ban करने वाला, thrombin antagonist या DIN, direct inhibitors. Now the very, very important question is, which of these is given orally? Which is the direct thrombin inhibitors given orally? That is your dabigatran. Remember, dabigatran and zimalagatran. Okay, these are given orally. Dabi, remember, direct. D, direct, given directly, that means orally. And Zimalagatran is XI. That means X matlab no, I matlab injection. So no injection for Zimalagatran. Remember tran, these are thrombin antagonists. So direct thrombin inhibitors. Okay, these are direct thrombin inhibitors. So which are the orally given direct thrombin inhibitors? If you have the question orally given direct thrombin inhibitors, it is dabigatran given directly oral and Zimalagatran. Remember D and XI. Okay, D and XI. Then you have your factor 10A inhibitors. Rivaroxaban. 10A को ban करने वाला. Apixaban. Okay, so 10A, again remember 10X, that means not given by injection. X matlab no injection. So 10A या Zimalagatran is no injection. These are given orally. And vitamin K inhibitors, that is your Warfarin. Even Warfarin is given orally. Okay, Warfarin is given orally. That is the difference, very important difference between Warfarin and Heparin. Is this clear with everyone? Is this easy to understand? Right? Is this easy to understand? Yes. So you just need to remember parin is parenteral. All your direct inhibitors, thrombin inhibitors, then troban, tran, they are parenteral except dabigatran and Zimalagatran. Even your factor 10A inhibitors, very, very important. These are given orally. Warfarin is given orally. Okay. So again, coming to your classification of anticoagulants. I hope all of you are able to see this. Do let me know if anywhere you're not able to read, so I will just zoom in the slide. Okay, vitamin K antagonist is Warfarin. Okay, we know that which are the vitamin K dependent clotting factors, 2, 7, 9, 10. Okay, plus you have your protein C and protein S. Direct thrombin inhibitors, oral direct thrombin inhibitor, dabigatran, and also add to the list Zimalagatran. Okay, Zimalagatran, XI and Dabi. Okay, rest are all parenteral. Now just to add to confusion, you have still further classification in this table, which is a monovalent direct thrombin inhibitor and which is a bivalent direct thrombin inhibitor. Now monovalent is ergotroban, rest are all bivalent. So remember that ergotroban, A is your first alphabet. That means it is monovalent. Rest all are bivalent. So remember ergotroban is your monovalent. Okay. Next, indirect thrombin inhibitors are basically your parin wale, all the parin. Unfractionated heparin, low molecular weight heparin, enoxaparin, dalteparin, tinzaparin, and you have fondaparinux. Okay, all the parin drugs are indirect thrombin inhibitors and they are given parenteral. Direct oral, okay, remember this is oral. Factor 10A, rivaroxaban, apixaban, edoxaban, batrixaban. Remember for batrixaban, it is used for prophylaxis of DVT, not for treatment. Okay, batrixaban is used for prophylaxis. Okay. Okay. Dr. Gaurav, I'll share the PDF on the Telegram group. I'm sorry I could not do it before the session. I will definitely share it after the session. Okay, so you can quickly go through this video again at 2x speed and just add on the points. Or for the time being, in your notebook as we are discussing, just jot down the mnemonics so that when you get the PDF, it becomes a quick review. Okay, I'll do that after the session. Alright. So just give me a quick thumbs up if everyone is up and not sleepy with pharmacology late night. I hope this is interesting and pharmacology is not as boring as it seems, right? Yes, a quick thumbs up? Okay. Now let's go to the next table and I hope all of you are okay with the speed as well. I'm going with a faster speed because I am assuming that all of you are appearing for exam on 12th of September. So we need to go at a faster speed ताकि हम बहुत सारा cover कर पाए in less time. Okay, chalo, that's great. Now coming to another very important table, that is differentiation of your Differentiation of heparin, unfractionated versus low molecular versus fondaparinux. Okay, very important. I'll just highlight the important points. Okay, I'll just highlight the important points here. So you have unfractionated heparin, low molecular weight heparin and fondaparinux. Out of this, if I ask you which of these is a pure factor 10A inhibition without any factor 2A, that is thrombin inhibition. So remember that where you have fondaparinux, where X is added in the spelling, that tells you कि ये है सिर्फ factor 10 inhibitor. तो ये एक important point है first वाला. So remember factor 10A inhibition is shown by all of these. Factor 2A inhibition is not shown by fondaparinux. X matlab it is 10 only. Okay, it is 10 only. The difference between unfractionated heparin and low molecular weight heparin is unfractionated heparin दोनों को equally inhibit करता है, 10A also and 2A also, while the low molecular weight heparin is 10A more. That means ये 10A की selectivity बढ़ती जाती है with the newer drugs. So unfractionated equal, low molecular weight 10A is more and fondaparinux only 10A. So that goes on increasing with the newer drugs. Okay. Now why is this so? Unfractionated heparin, because it has long chains. So the long chains act on both 10A also and 2A also. Low molecular weight has mixture of long also and short also. While fondaparinux, remember it's a pentasaccharide. Okay, it's a pentasaccharide. Remember that, another point. Now next one, bioavailability. Now all of these are parin. All of these are parin drugs. So oral, none of these will be absorbed orally because all of these are parin. So another important point to be highlighted. Next one, your unfractionated heparin, subcutaneously it is not good absorption. It's IV only. Why? Understand the concept, because it has long chains. So if you give subcutaneous, it is not absorbed well. So that is why heparin unfractionated is IV, while the rest of them have good subcutaneous absorption. जैसे जैसे कम होगा chain, absorption अच्छा होगा. तो fondaparinux will have very good absorption subcutaneous. Now since your unfractionated heparin, it is metabolized by the reticuloendothelial system. It's a long chain wala polysaccharide. So it is metabolized by RES. So it has clearance which is very variable. So the clearance is variable. So you see variable response with unfractionated. While the rest of them, the rest of the two are cleared by the kidneys. So they do not have variable response. You have predictable response. Now since your unfractionated heparin is metabolized by reticuloendothelial system, so it is safe in renal impairment, while the rest are relatively unsafe. This you can use unfractionated low molecular weight with close monitoring, while fondaparinux is absolutely contraindicated. So remember this important point. Unfractionated is safe in renal impairment because reticuloendothelial elimination. Because it has a variable response, okay, your unfractionated has a variable response, that is why you need monitoring. कभी किसमें कैसा response होगा, कभी कम होगा, कभी ज़्यादा होगा. So you need monitoring, and the monitoring is required by APTT. Okay, that's your APTT which requires, so remember happy. Okay, so like you remember happy, heparin is APTT, happy, heparin is happy. So APTT, okay. And with your low molecular weight, you require monitoring not routinely because it's not a variable response, it's predictable. But only if there is renal impairment, because it is eliminated by the kidney. Renal impairment होगा तो कितना excrete हो रहा है नहीं हो रहा है वो मालूम नहीं पड़ेगा. इसीलिए we need monitoring only with renal impairment, and the monitoring is required by factor 10A aside, not by APTT. Remember that point. Because it has 10A activity more than your 2A activity, that is why the monitoring is by 10A. Fondaparinux, you do not need any monitoring because you are not giving in renal impairment. So there's no question of variable response. So no monitoring is required with fondaparinux. Protamine sulfate, it reverses your unfractionated because it acts on the long chains, and long chains are present in unfractionated. With your low molecular weight, it's only partial reversal because it acts only on the long chains, so the short chains are not affected. So only partial reversal. While with fondaparinux, there is no reversal because there are no long chains in fondaparinux. It's a pentasaccharide. The side effects, heparin-induced thrombocytopenia, osteoporosis, all these are more with unfractionated. The newer drugs are developed so that the side effects become less. Okay, the side effects are more with unfractionated. Okay. So remember about this one. Now everyone is clear with this table. What is the advantage of unfractionated heparin? It is safe in renal impairment. That is the advantage. Otherwise, it has more side effects. You cannot give subcutaneously. Other advantages, you have protamine, which causes full reversal. Monitoring for low molecular weight is required only in renal impairment with factor 10A. Fondaparinux is contraindicated in renal failure. Okay. All right. For when you have your heparin-induced thrombocytopenia, so in that case, you give your direct thrombin inhibitors. Okay, then in that case, we give direct thrombin inhibitors. Do not give platelet infusion because basically there are antibodies which are responsible. So platelet ko bind, okay, that will not be effective. You have to give direct thrombin inhibitor. Okay, direct thrombin inhibitor. All right. Now coming to another important table, which is your difference between heparin and warfarin. Now heparin, remember, it's a large acidic polysaccharide. Warfarin is a small lipid soluble molecule. This is given parenterally, heparin. Warfarin is given orally. Heparin basically acts on the blood, the clotting factors which are there in the blood. While warfarin acts on the liver. It is your vitamin K antagonist. So your synthesis of the new clotting factors is affected. So think logically and tell me which one will be faster acting. Heparin will be faster acting क्योंकि वो direct blood में act कर रहा है. Warfarin, the onset is delayed because only the new synthesis is inhibited. The clotting factors which are already there in blood are acting. So remember, onset of action rapid with heparin and it is slow in days with warfarin. This is within minutes because it acts on the blood, right? Mechanism of action, very, very important. Heparin basically acts by activating antithrombin 3. Important question, it acts by binding to antithrombin 3. Now what does this antithrombin 3 do? Antithrombin. So it inactivates, it stops your clot formation. It inactivates coagulation factors thrombin 2 and factor 10. Dono 2 and 10. While this is affecting your post-translational modification. Tell me, what is the post-translational modification seen which is inhibited by warfarin? Which post-translational modification is inhibited by warfarin? Is it hydroxylation? Is it methylation? Is it carboxylation? Which is affected? Suchitra, okay, I'll zoom it a bit more. Yes, absolutely. So remember, it's inhibiting your vitamin K, and vitamin K, remember K for, we do not write as C but K, it is carboxylation. कौन सा carboxylation? Gamma carboxylation of your GABA wale, okay, glutamate wala in the clotting factors. All right. Monitoring, happy, heparin is happy, APTT for unfractionated, but not for low molecular weight. Low molecular weight only if it is renal impairment. Even in that case, the monitoring is required by 10A. While for warfarin, you need prothrombin time. Okay, for warfarin, it is prothrombin time. Antidote, you have protamine for unfractionated. With low molecular weight, it is only partial reversal. For warfarin, because it's a vitamin K antagonist, the treatment is to give vitamin K1. Remember, it is vitamin K1. You can give plasma. That means direct clotting factors is what you can give. Use For acute use, basically we will use heparin, and then for chronic use, then we will change to warfarin. Pregnancy mein which is safe? Heparin is safe in pregnancy. Warfarin we know causes a lot of teratogenic effects. Heparin does not cross the placental barrier. Warfarin is a small lipid soluble molecule. It will cross the placental barrier, while this is acidic, so more ionic. Okay, so warfarin will cross and cause the teratogenic effects. We know your nasal cartilage, your epiphysis, all of that is affected. Okay. Yes, another important point, very correct Dinesh. So vitamin K dependent, you have protein C and protein S as well. So even those are decreased. That is why it will cause the dermal necrosis as a side effect. Okay, it can cause your dermal necrosis as a side effect, which will be seen with warfarin, because protein C and protein S are also inhibited. Okay, so you will get initial prothrombotic wala state, because protein C deficiency is a prothrombotic state. So similarly, when protein C is inhibited, prothrombotic state, purple toe syndrome, dermal necrosis is what we will give. Okay. Yes, so absolutely, basically you have to give the ready-made clotting factors in acute cases when there is warfarin toxicity. And if asked what is the best antidote or specific antidote, then it is vitamin K1. Acute में अगर पूछा तो आपको FPP देना पड़ेगा. Okay. Alright, so everyone clear with this? Anticoagulants, heparin, warfarin, low molecular weight, fondaparinux, direct thrombin inhibitors, which are given orally, dabigatran and zimalagatran. Rivaroxaban is also given orally because it is XA, X matlab no injection. Okay. Again, quick points about your low molecular weight, क्योंकि ये बहुत important topic है. What is the advantage? Bioavailability is more. Half-life is more. The release of tissue factor pathway inhibitor is not seen. Antidote we do not have for low molecular weight. It's only partial reversal. That is the disadvantage with low molecular weight. Okay. So the disadvantage with low molecular weight heparin is you do not have an antidote which will cause full reversal. Protamine will be only partial reversal. Again, advantages, it has advantages of low molecular weight. Just a second. Better bioavailability, longer T-half, dose independent clearance because it is renal elimination. So you have predictable response, less side effects. So low heparin induced thrombocytopenia, low osteoporosis. So that is what is the advantage of low molecular weight heparin. Okay. Next one, let us go now to your fibrinolytics and antiplasmin drugs. Okay. So you have fibrinolytics, that means breaking the clot. So thinking logically, where will be the fibrinolytics used? Where you have a clot. Okay, where you have a clot. Stroke वगैरह में use करेंगे thrombolytic या fibrinolytic. While you have antiplasmin drugs, ये उल्टे में use करेंगे. Where do we use antiplasmin drugs? Where do you use antiplasmin drugs? That means you want the clot to be there. Nitin is saying there is audio issue. Is everyone facing the audio issue or the audio is fine? Yes. So basically antiplasmin drugs, Tranexa, बहुत बार you must have seen in your internship practice, gynecology में menorrhagia का patient, PPH का पेशेंट, ओके, वहां पे ट्रानेक्सा यूज करते हैं. सो PPH दैट मीन्स बेसिकली मेनोरेजिया PPH हम हेमरेज में यूज कर रहे हैं जहां ब्लीडिंग ज्यादा है. ठीक है. सो एंटीप्लाज्मिन आर यूज्ड देयर. सो योर प्लाज्मिनोजन इज एक्टिवेटेड टू प्लाज्मिन एंड इट कॉजेज योर क्लॉट lysis. So you have plasminogen activators which are used as thrombolytics. I'll come to that table. Which are the antiplasmin drugs? Remember antiplasmin, AN, aminocaproic acid and tranexamic acid, AN wale. Aminocaproic acid and tranexamic acid, these are your antiplasmin drugs. Now which are the plasminogen activators? Thrombolytic, alteplase, right? Retinoids, tinacteplase. These are basically your plasminogen को activate करने वाला, plasminogen को break करके plasmin में convert करने वाला. So all your plase वाले drugs, plasminogen को break करने वाले. So you have alteplase, retinoids, tinacteplase, and you have streptokinase. Streptobacteria, it's a bacterial protein. These are recombinant human tissue plasminogen activator, alte, rete, and tenecte. Okay, so they convert plasminogen to plasmin, which degrades the thrombi. So they are used in coronary artery thrombosis, ischemic stroke, pulmonary embolism. They are given parenterally. And what is the major side effect that we should be cautious about? Bleeding. Okay, because of the clot lysis, there will be bleeding which can occur. Now, very important point here, which is fibrin specific and which is non-fibrin specific. So remember, fibrin specific is your RAT. Remember that RAT is fibrin specific. So you have retinoids, alteplase, and tinacteplase. This is fibrin specific. While the rest, streptokinase, N-streptase, urokinase, आपने ये याद रख लिया. You do not need to remember this. Remember that RAT is specific. RAT is fibrin specific plasminogen activator. That means bound to the clot. Okay, bound to the clot. So streptokinase, it is least fibrin specific and it has the lowest incidence of intracranial hemorrhage. Okay, so the lowest incidence is seen with intracranial hemorrhage. Which is most fibrin specific? RAT में जो T सबसे आखिरी में है tenecteplase. Okay, that is most one and it's given as a bolus. Okay, it's given as a bolus. So the only point to remember here, fibrin specific है RAT, streptokinase fibrin specific नहीं है and it has minimum intracranial hemorrhage. Okay. Now coming to the quick table of reversal agents. कौन से reversal agents होते हैं? अगर आप विटामिन K1 कब दोगे? That is phytonadione. K1 is phyto. It is warfarin toxicity. Okay, it is used for warfarin toxicity. So warfarin के लिए, विटामिन K deficiency के लिए. Protamine कब देते हैं? Protamine is for unfractionated heparin. Okay, unfractionated heparin. Factor 8 hemophilia के लिए देंगे. Then you have desmopressin. Remember desmopressin, vasopressin. It increases your von Willebrand factor and factor 8. Very important. It increases your von Willebrand factor, which is responsible for factor 8 activity. उसके लिए important है. Antiplasmin हमने देखे already. Aminocaproic acid and tranexamic acid. When will you use these drugs? When you have given excess of thrombolytics. So उसका opposite is antiplasmin. So when there is excessive fibrinolysis, then you use antiplasmin drugs. Okay, antiplasmin drugs. Reversal agents वापस heparin, protamine, warfarin, vitamin K, rivaroxaban और बाकी 10A के लिए it is Ndexanet alpha. Okay, remember that Ndexanet, it is antagonist for 10A. Ndexanet, XA tells you that. Dabigatran का reversal agent है idarucizumab, जो भी spelling है idarucizumab. Okay, so remember DA is DA. Dabigatran का reversal है idarucizumab. DA is DA. XA, Ndexanet is for XA. Okay, Ndexanet is for XA. Is that clear with everyone? Right? So I think we are done with the topic of anticoagulants. Antiplatelets, anticoagulants, done. If I ask you a question, ticagrelor, what is the mechanism of action of ticagrelor? What is the mechanism of action of ticagrelor? Is it your antiplatelet? Is it your anticoagulant? Is it your fibrinolytic, antifibrinolytic? And what is the mechanism of action? Very good, Srinidhi. Absolutely right. So it is ticagrelor. OR is temporary ADP, that is reversible ADP receptor antagonist. Absolutely right. And it is your antiplatelet drug, right? It's your antiplatelet drug. And which is your thrombin receptor antagonist? Paxar wale drugs, right? Vorapexar, Atopexar, these are your thrombin receptor antagonist. Okay, these are thrombin receptor antagonists. So fondaparinux, can we give fondaparinux in renal failure? Yes or no? Can we give fondaparinux in renal failure? Absolutely. Remember that it's contraindicated. Okay, it's contraindicated. You do not need any monitoring with fondaparinux. You don't give it in renal impairment. Low molecular weight can be given with monitoring. And how do you do the monitoring for low molecular weight heparin? How do you do the monitoring for low molecular weight heparin? Absolutely right. That is your factor 10 ASI. And protamine does not reverse your low molecular weight heparin. Only partial reversal is seen. And remember andexanet and idarucizumab. Alright. So that was about this topic. Antiplatelets, anticoagulants, thrombolytics done. RAT is fibrin specific. Remember that. Streptokinase is not fibrin specific. It has minimum intracranial hemorrhage ka side effect. Okay, now let us quickly go to the topic of anti-epileptics. Okay, so anti-epileptics pe chalte hain, mechanism of action and side effects. That is what we would be seeing. If I show you this image, tell me which anti-epileptic drug causes this side effect. Absolutely right. That is phenytoin. Okay, that is phenytoin which causes gum hyperplasia. Okay, this is phenytoin which causes gum hyperplasia. Do you remember another drug we saw in one of the recent sessions where we discussed the drug used to prevent your acute kidney transplant rejection? Calcineurin wala drug which causes gum hyperplasia. Absolutely right, Viruksha. Yes, AJB, that is cyclosporin. Okay, cyclosporin, phenytoin, at least ye do yaad rakhna for gum hyperplasia. Now, tell me this one. Which anti-epileptic causes visual field defects? Visual field defects, not blurred vision. It is visual field defects. Very, very important and frequently asked. Remember VI, visual field defects, vigabatrin. Okay, it is vigabatrin. What is the mechanism of action of vigabatrin? It is GABA transaminase inhibitor. Okay, it is your GABA transaminase inhibitor. That means your GABA metabolism is decreased. So GABA levels increase. Okay, GABA levels increase. Homicidal ideation is a side effect seen with? Homicidal ideation is a side effect seen with? So remember homicide, who does homicide? Someone who becomes paranoid. Okay, so remember homicidal ideation, someone who becomes paranoid, that is your parampanel. Okay, it is parampanel. What is the mechanism of action? Parampanel, AMPA. It acts on AMPA, parampanel. So it is paranoid, homicidal and AMPA. Hepatotoxic, alopecia, thrombocytopenia. These are the side effects seen with hepatotoxicity, especially in infants. We need to be very careful of that. Absolutely right. That is your valproate. Now valproate ka side effects yaad karna is easy. Valproate, tell me whether it's an enzyme inducer, cytochrome P inducer or cytochrome P inhibitor. Is it cytochrome P? Is it enzyme inducer or is it enzyme inhibitor? The trick to remember for valproate is remember VALP. Okay, VALP. V मतलब ये ऐसे नीचे का एरो है, नीचे वाला एरो है, मतलब एंजाइम को नीचे लेके जा रहा है. It is enzyme inhibitor. The rest like phenytoin, your other drugs, they are your enzyme inducers. Then you have AL, valproate. AL is alopecia. Okay, AL is alopecia. Then you have ALP. Remember like your ALP, ALT. These are liver enzymes. So it causes liver toxicity. That means it causes your hepatotoxicity. Then you have LP. LP matlab low platelets. That means it causes thrombocytopenia. So you have all the side effects which are included in your valve. Okay, which are included in your valve. So remember, yes, it causes weight gain as well. Valproate, it is VAL is also for your V for weight. Okay, WAL is for elevation. Valproate causes weight elevation. That means it causes weight gain. Similarly, V wala dusra drug, Vigabatrin, also causes weight gain. Okay, I'll come to which are the drugs which cause your weight loss. So is this clear with everyone? Valproate, it is your weight elevation, it is enzyme inhibition, it is alopecia, hepatotoxicity, it is low platelets. That means it is thrombocytopenia. Okay, it is thrombocytopenia. Next one, gum hyperplasia. हमने कहा it is phenytoin, right? It is phenytoin, and then you have. So I can just now think of a mnemonic for your gum hyperplasia. Remember the two toothpaste. You have Pepsodent and you have Colgate. So P और C वाले drugs, phenytoin और cyclosporin. So gums पे लगाते हैं, hypertrophy हो जाएगा. Pepsodent and you have your Colgate. Gum hyperplasia, even your osteomalacia, that all is seen with phenytoin. You have fetal Hydantoin syndrome. Fetal Hydantoin, remember important finding, you have hypoplastic phalanges. Remember, phenytoin affects the phalanges. Hypoplastic phalanges, cleft palate, microcephaly, all of this is seen with phenytoin. That is your fetal Hydantoin syndrome. Okay, fetal Hydantoin syndrome. SJS, if the question is only on SJS, no other associated, commonly used drug, that is your lamotrigine. Okay, commonly used drug, lamotrigine causes your SJS. If you have SJS, that is Stevens-Johnson syndrome, along with diplopia and ataxia, then which is that drug? When you have all of this together, then it is your carbamazepine. Okay, then it is your carbamazepine. What is the mnemonic for carbamazepine? Remember CB, it is your A, B, C, D, S. Okay, A, B, C, D's is CBZ. That is, so when you are saying CBZ, basically you are saying A, B, C, D, E, right? So A, B, C, D's. So you have ataxia. Okay, it will cause ataxia. It causes blood dyscrasias. Okay, it causes blood dyscrasias. That is why you need to monitor CBC with carbamazepine. Okay, CBC monitoring. CBZ requires CBC monitoring. Okay, then you have C. Then you have your diplopia is seen, Stevens-Johnson syndrome is seen, your counts are affected, all this is seen with carbamazepine. Okay, all this is seen with carbamazepine. So that is the mnemonic for carbamazepine. Abhi dekh lo quickly ye table, a quick revision. Are all of you able to see this table? Right, I hope all of you are able to see this. Yes, so quick revision with the mnemonics. Carbamazepine ka mnemonic hai. Carbamazepine is A, B, C, D's. Okay, so you have ataxia, you have diplopia, you have Stevens-Johnson syndrome, and remember you have blood dyscrasias, you require CBC monitoring. Phenytoin, Pepsodent, gum hyperplasia, hirsutism, osteomalacia, ataxia, very very important. Cerebellum को affect करता है, it causes dose dependent side effect at high dose, nystagmus and ataxia. These are your dose dependent side effect of phenytoin seen at high dose. Valproate, we saw the mnemonic. Valproate, it causes alopecia, low platelet, that is thrombocytopenia, ALP, hepatotoxicity. It is enzyme inhibitor, right? It is enzyme inhibitor. That is what we saw. Phenobarbital, हम सबको पता है barbiturate, they will cause sedation, depression and all of those. Vigabatrin, peripheral vision is lost. That means it is visual field defects. Felbamate, what are the side effects seen with felbamate? The trick to remember is felbamate के साथ fail होता है bone marrow और फेल होता है लिवर. So it causes bone marrow suppression, aplastic anemia, that means it causes aplastic anemia, and it causes fulminant hepatic failure, that means fail hota hai liver, fail hota hai bone marrow. Lamotrigine we said, Steven Johnson, hypersensitivity. Topiramate and zonisamide, these are the two drugs which cause your renal calculi and weight loss. Now to remember this, that which are the drugs which cause renal calculi, okay, they cause renal calculi and they cause weight loss. So remember OO वाले drugs, calculi कैसे होता है, round round. Weight loss मतलब क्या हो रहा है, weight हो रहा है zero, okay, so weight is dipping towards zero, that means zero. So OO वाले drugs, that is topiramate and you have zonisamide. So remember this O, topiramate and zonisamide, this OO wala are the drugs which cause renal calculi and weight loss. Now in the question, along with renal calculi and weight loss, if you have acute glaucoma and you have paresthesias, then it is topiramate. So to remember this, remember topiramate is rhyming with tropicamide, a drug used in the eye, tropicamide. So it is eye wala side effect, glaucoma is seen. And paresthesias, let's say in the toes, paresthesias in the toes, that is again topiramide. So topiramate, toes mein paresthesia, tropicamide, glaucoma. Okay, these are the side effects. Oxcarbazepine as compared to carbamazepine, it causes hyponatremia. Very, very important. It causes hyponatremia. That is important to remember. Ezogabine, which is basically your retigabine. Ezogabine, like your retigabine. Retiga, RET, it causes retention, urinary retention. Ezoga, that is easy, go. So the urine does not go easily. It's a misnomer drug. So ezogabine, urine does not go easy. It causes urinary retention. So remember, retigabine causes retention. Another side effect with retigabine, remember RET, it causes deposits in the retina. So it can cause blurred vision and it causes deposits in the skin as well. So retigabine. Can you tell me the mechanism of action of retigabine? नहीं, अगर O is in many drugs, so Suraj, O many drugs में ऐसे वाला याद रखना, TO and ZO, TOZO. Okay, that is second alphabet is O. And in none of the other I can see you have your second alphabet which is O. Okay, so TO and ZO, that is where you remember OO. Absolutely right, it acts on your potassium channel. Again we remember this as Retiga, R you write is similar to K, right? R is very similar to K. You just remove upar ka, that becomes K, right? So retigabine, remember it acts on the potassium channels. Okay, it acts on the potassium channels. Not on sodium channels, not on calcium channels. It acts on potassium channels. Then perampanel हमने देखा, ये हो जाता है paranoid, that means homicidal ideation. Paranoid, सबको kill करने वाला. Which anti-epileptic drug can cause your psychosis, hallucinations? It can cause psychosis, it can cause hallucinations. A new drug commonly used, that is your levetiracetam. Remember levetiracetam? It causes psychosis, hallucinations. But specifically homicidal पूछा, patient having behavior problem, anger, that is perampanel. Okay, that is perampanel. So मैं zoom करूँ एक बार तो will you be able to take the screenshot? I am not sure. Let me know. Okay. So everyone is clear with the side effects? The side effects of anti-epileptics? Yes. Now let us, I think this is the last table that we would be seeing. It's almost midnight. So the last one we are seeing is mechanism of action of anti-epileptics. We do have other tables, the mnemonics to be discussed. What I'll do is I'll discuss it in the upcoming special class. Okay, so what we can do is day after tomorrow We can discuss the rest of Pharmacology Mnemonics. Tomorrow 5 p.m. We will discuss the plan, the next 10 days plan, what you should be doing, what you should not be doing, whatever queries you have, what to read in this last 10 days. I'll give you a timetable as well, how you should complete your syllabus in the remaining 10 days. Okay. Dr. Gaurav, I have taken anti-cancer drugs in the plus, detail में लिया है, HIV drugs लिए हैं, AKT drugs, antimicrobials, general pharmacology. Many of that I've taken on the plus as well. So if you're there on plus, do watch those sessions. It will definitely help you. Right, let us quickly see the tricks for mechanism of action of anti-epileptics. So all your major drugs, जो हम common वाले पढ़ते हैं, phenytoin, carbamazepine, valproate, all of these act on sodium channel. Okay, they act on sodium channel. Even lamotrigine is sodium channel. Barbiturates, benzodiazepines, we know when we read in your sedatives, hypnotics, they act on your GABA chloride channel. Okay, they act on GABA chloride. Basically receptor पे act करते हैं. GABA transaminase is vigabatrin, GABA transaminase inhibitor. It is GABA transaminase inhibitor. That is your vigabatrin, visual field defects. Inhibits GAT1. Now what is this GAT1? GAT1 is the receptor which is causing reuptake of GABA. Basically GABA को वापस लेके जा रहा है. So it is decreasing the GABA का levels. So when you inhibit your GAT1, the GABA levels increase. That is what you want in seizures, right? Because it's an inhibitory neurotransmitter. So that is tiagabine. So that is, you can remember as tiagabine. Okay, tiagabine. It is GABA, that is GAT1, T1 inhibitor, that is GAT1, tiagabine. Then you have the next one, which is your SV2A पे एक्ट करने वाला लेवे, जिसके स्पेलिंग में V आता है, जिसके स्पेलिंग में VE आ रहा है, that is लेवे, that is your SV2A. Synaptic vesicles पे basically उस पे एक्ट करने वाला, that is levetiracetam. Potassium channel opener, it opens the potassium channels. K is like R, retigabine or ezogabine. What is the side effect we saw? Retention and retina deposits. NMDA receptor को block करने वाला. NMDA is a receptor for glutamate. So excitatory को block करने वाला. NMDA glutamate is felbamate. Okay, so glutamate से rhyming is felbamate. What is the side effect we saw with felbamate? What is the side effect we saw with felbamate? फेल्बामेट क्या क्या फेल होता है फेल्बामेट से, फेल्बामेट का निमोनिक क्या क्या फेल होता है, बोन मैरो फेल होता है और लिवर फेल होता है. सो यू हैव हेपाटोटॉक्सिसिटी, fulminant hepatic failure and you have aplastic anemia, right? फेल, यस. AMPA रिसेप्टर को ब्लॉक करने वाला, AMPA NMDA ग्लूटामेट के रिसेप्टर्स, पैरम्पनेल, पैरानॉइड हो जाता है, होमिसाइडल आइडिएशन. दिस इज ब्लॉक्स T टाइप कैल्शियम चैनल्स, नॉट L. T type, it is your ethosuximide, ET, it is your ethosuximide. It inhibits your T type calcium channels, right? So you have sodium channel blockers, you have calcium channel blockers. This is potassium channel opener, not potassium channel blocker. GAT1 is tiagabine, GABA transaminase is vigabatrin, potassium channel K is R, retigabine, NMDA is your glutamate, felbamate, AMPA is perampanel and T-type calcium channels is ethosuximide. ये है आपका GABA. Now look at this image. Okay, now tell me which drug is what. If I ask you which is this drug E, what will be the answer? Which is this drug E? Yes, ethosuximide. We all know absent seizures, blank stare look you have. 3 Hz spike and wave pattern on EEG. Then you have precipitated by hyperventilation. All of those we've seen in the recent one. Absolutely right, because it's acting on the potassium channel. Potassium K is R, retigabine, side effect retention, urinary and retina deposit. Okay. ये वाला drug बताओ कौन सा है? F वाला, which is this drug? F is your AMPA receptor, that is your parampanel. AMPA you can see is a receptor for glutamate. दूसरा receptor for glutamate NMDA. NMDA पे act करने वाला felbamate. Okay, it is felbamate. Which is this drug B? Which is this drug B here? SV2A. SV2A पे act करने वाला, that is levetiracetam, right? Levetiracetam. Then which is this drug C here? What do you think is this drug C? C is inhibiting your reuptake GAT1, GAT-T1, TI, that is your tiagabine. Okay, that is your tiagabine, which is your C drug, right? And D वाला drug कौन सा है जो GABA chloride receptor पे act कर रहा है? Those are your barbiturates and benzodiazepines. Okay, barbiturates and benzodiazepines. बाकी आपके ये सोडियम चैनल पे एक्ट करने वाले फेनिटोइन, वेलप्रोएट, कार्बामाजेपिन और लैमोट्रिजिन. Where is ethosuximide? Ethosuximide is here. T-type calcium channel, that is ethosuximide, right? That is ethosuximide. Alright, so that was about this session, guys. As I said, we have more topics to discuss. I'll do it in the upcoming free live classes on Unacademy app. I generally take classes at 5 p.m. You can follow my profile, and whenever you are joining for the class, if asked for a code to unlock, you can use the code Dr. Nikita to unlock the free live classes or even to give the grand test. Okay, so you can use that code, and I hope to cover many more high yielding topics in these last days for your final revision. Okay, for your final revision. Clozapine के side effects बता दूंगी आने वाले session में. Do not worry on that front. I hope all of you enjoyed this session and found this high yielding. And please do share this with other your colleagues as well. This is what we have to discuss. Antimicrobials था, उसके बाद आपके mechanism of resistance of the antimicrobials, antifungal drugs. We have anti-diabetic drugs that we had to discuss. We have many new drugs that I had to discuss, the monoclonal antibodies and all. So there was quite a few other topics that I wanted to discuss. I'll do it in the upcoming sessions. Please download the Unacademy app. Okay, you'll find the link in the description to join the classes. And do not forget to subscribe to this channel. And do let me know in the comments how did you find this session so that we can plan more such sessions in the future. Okay. So thank you so much everyone. Goodbye. Take care and keep studying, keep revising and keep winning. And remember, this is a very crucial time, these last 10 days. Stay motivated. Stay confident. Do not start having the doubts creeping in. You have studied enough. You've done all the hard work. Now it's time to get the fruits for that hard work. So just keep pushing till the last day and all the very best. Thank you so much. Good night and take care.